Good evening, everybody. You're very welcome. Very pleased to have you here with us this evening. I'm joined by Anne Derham of Fethard Equine Hospital here this evening. Anne, you're joined in there with two different logins. That's okay with you, yeah?
Yeah, I'm not sure why.
Yeah, just check that maybe while I'm doing the introductions there. So Anne is based down in Tipperary, down in Fethard Equine Hospital. Delighted to have you with us here this evening, Anne. I'm really looking forward to hearing all about the work that you do and your colleagues do down in Fethard. And I suppose, before we get going this evening, just a kind of a note to people on a couple of fronts. Number one, we really appreciate people's questions and love to hear from you. You can use your Q&A button, which most people will find at the bottom of their Zoom screens, to input your questions. Please, that in preference to using a chat function. Secondly, I suppose just given the nature of some of the content this evening, we are speaking to an equine surgeon, and some of the material for some people might feel that it's a little bit graphic for their eyes. So we're giving the health warning here at the start. We may repeat it in a couple of minutes again, but if you're of that mind, then please tune into the audio as opposed to the visual of this webinar. Without further ado, and thanks so much for giving up some of what I know has been a very busy day already to be with everybody this evening and to give your information. So
no problem at all. Thank you very much for having me. I'm always very, very happy to discuss and talk about the work and that. So more than happy to present this evening, and I hope there's a lot in it, and as you warned, they're quite graphic images. So I do apologize, but I think it was necessary to show some of what we do as for an elective or a referral centre. Mm-hmm. So yeah, without further ado, I suppose will I kick on?
Well, I was going to say, Anne, even before we kick into the formal presentation bit of it, look at, you might be new face to some, those that maybe haven't been down in Fethard of more recent time. Maybe if you just, to begin with, give a little bit of an introduction as to your own career path to date and, where you're coming from in that regard.
Yeah, absolutely. I have put it into the program. So what I'll do is I'll start.
Start your screen share. So yeah. That's great. So you just pop that up into full share mode. I'm confirming that I can see it at this side.
Okay, can everyone else see that then?
Yeah, I can see it, so everybody else will. Yeah,
great.
Perfect.
So obviously what we're going to talk about tonight is what an equine referral clinic does and what that means with regards to clients and what we offer service-wise all year round. Mm-hmm. So as Wendy said, my name is Anne Derham. I am a boarded diplomat in the European College of Veterinary Surgeons under large animal surgery, which specifically covers equine surgery as well. Mm-hmm. So just an overview very quickly over what we're going to talk, obviously what is a referral equine clinic, and then the services we offer, and then we'll go into questions and discussions. But I think, Wendy, we're going to go into kind of, we can stop in between or during the presentation. I'm more
absolutely. So people can throw in their questions into the Q&A there, and I'll keep an eye on them as we go.
Yeah. So background for me then, I graduated back in 2014 from UCD in Dublin. From July 2014 to July 2015, I was a surgical intern in Haggards in Kentucky. Following that, then I did another surgical internship, and that's where I first landed down in Fethard, and I came down and did a year down here. And then following that, I went on to do my surgical residency program. So I was accepted up to UCD in Dublin again. And that's a 3-year program. And during that, then you also, we do a concurrent professional doctorate. My doctorate was on the impingement of dorsal spinous processes and their effect on the performance of the thoroughbred race of horse population. So I finished up that doctorate in 2019 and obviously defended it successfully. Following that then, so once I finished my residency, while I was waiting to sit my board exams, I went to the UK and was a solo surgeon based up in Yorkshire. So I worked there from September to May 2020. I came home earlier than expected due to the COVID issue and just wanting to get back, move back to Ireland. Following that, then I did another year, just over a year up in Sycamore Lodge as a surgeon. And then I came back down to Fethard in September 2021, and I've been there since. Again, working with 3 other surgeons for the most part, and then we've now got a 4th, so there's 5 surgeons down here now. And then in February 2022, I was actually accepted as a boarded specialist in by the European College of Veterinary Surgeons. And also during my free time, I do locum lecturing for Ross University in St. Kitts. So I would teach the final years or their final year stages before they go into their clinical training programs. That's all about me. So what is a referral centre? So basically when specialist equipment or techniques are needed to diagnose or manage a problem, that's when a referral centre or a third-based clinic is requested or looked for. Typically the route that goes is that you'll see your first opinion vet, and then you will come to your first opinion vet will normally refer you on if they're not happy or they feel that there's more treatment or more investigations needed that they can't offer. And depending on your referring vet, that actually, that might be quite I won't say low level, but like it's a varying kind of degree of when they will send for referral. So some clients, their vets mightn't necessarily be very good at ultrasounding or mightn't have the right ultrasound equipment. They might send it on for an ultrasound. Whereas another vet may have their ultrasound and x-raying equipment, but they might want more advanced imagery. So they'll send on for CT or MRI. So there's a varying kind of degree of what will get sent.
And I suppose, Anne, even to say at this stage, that you serve the whole sector. It's not just a thoroughbred focused service that you provide.
No, exactly. We cover, so thoroughbreds, we're based in a highly concentrated thoroughbred region down here, but for sure, and we have a lot of sport horses as well. So sport horses, thoroughbreds, we do pleasure horses then as well. And your simple hack horses, etc. And then we also see a lot of the pacing horses, so the racing pacers. So we do get a good variety down here. And the only thing I suppose we don't see would be polo horses, are probably the ones I wouldn't see down here. So our hospital then is led by European and American recognized specialists. So that's the ECVS and the ECVS. There's 4 of us in our hospital at the moment. So that's myself, Ger Kelly, Shauna Lawless, and Matt Coleridge. And that's kind of typical of all referral centres. Like there is usually a boarded specialist there, because boarded specialists are at the highest peak of the profession. You can't really get any higher at that level. Our clinic, obviously, we have state-of-the-art facilities and technology. That's again kind of commonplace amongst referral centres. We offer advanced diagnostic imaging, so MRI, CT, and for horses in particular, dynamic endoscopy. So that's your onboard scoping. Then from a side that I try to steer clear of as much as possible is the medicine side. So the medicine department in our clinic, and they'll offer intensive care for adult horses, neonates, and older foals. So that's and that's very much on intensive care management. And I'll just touch on that towards the end of the presentation. And the other thing for a referral centre like ourselves, we offer 24 hours, 7 days a week emergency service. Like our clinic is never closed, and that's just tough as it is sometimes. That is the reality of our veterinary industry, is you need to be available, and that is 365 days a year. So that includes Christmases, New Year's Day, birthdays, weddings. There is always someone here at the doors to let you in. So
yeah.
Right. So moving on then. So initially, advanced imaging is probably the biggest section here for us from a referral centre. We have a unit, these are just a couple of images. Anyone who was at the tour for the young breeders that might have been in, if they're online or on at this presentation tonight, they would have been able to come in and have a look at this during the tour. So the MRI, big thing we use it for is foot injuries. It's specifically for soft tissue injuries, navicular injury, coffin joint diseases, and then solar penetrating wounds as well. I suppose the upside to the MRI is that you're getting a massive, you're getting a lot more detail than what you'll see on an X-ray or ultrasound. Especially with the foot, it's quite problematic for X-ray. Yes, you'll see the bones. Very hard to see soft tissue issues with an X-ray. And then ultrasounding through a hoof capsule is and through the sole of a foot, very, very difficult. You can get some images, but to get a really definitive diagnostic, MRI is superior. Now, also we look at pastern and fetlocks, again, bone and soft tissue injuries around here, and then potentially proximal suspensory ligament injuries in the forelimbs. I don't think we use it very much for that. I would say the predominant one we're using for it is foot injuries. But for that now, obviously the upside is it's a standing procedure. They're heavily sedated. We need them to not move. We have to pull everything that's metal has to come off them. So that means all their shoes have to come off. The nails, we need to make sure we get all of the nails. You're not leaving the heads and nails, because this is just a gigantic magnet. That is what it's a magnetic resonance imaging system. So that can be a little bit problematic. It also takes quite a long time to actually process or get an image. So that's why it takes a long time. They need quite a bit of sedation to make sure they stand still. You don't want them moving at all. That's going to disturb the image. And while
I was just going to say, and like I suppose you said, you in your opening slide you emphasized, I suppose, the qualifications of the staff that are there and the strength of the surgeons and so forth. But and obviously the other kind of, I suppose, feather in the cap is this type of equipment and the uniqueness of it and the ability of it and so forth. But I guess the other side of the conversation then that you have with a client is around, I suppose the value of a given patient, shall we say, relative to the cost of some of these interventions and how suitable that is then in the scenario at stake.
Absolutely, and I think that's a mark of our job is that, and getting into this, this particular imaging technique, it takes longer than CT to do, but the other issue with this is the cost issue. And whilst it is a superior modality, you have to take into account that an image for this, roughly, you're looking at over €2,000 to take an image of a foot. That's an awful lot of money to tell you a diagnostic for a client when without even performing any form of treatment thereafter or surgery. So for sure, this is something that is very much, it's cost prohibitive for a lot of clients, but it's something that is there and to be aware of.
Yeah, absolutely.
Yeah. And I would also say, like, we have our own radiologists and radiographers. So when we take these are obviously specialized images. Again, we're being boarded. We have to be able to read them and interpret them. But there are actual, there are radiologist specialists. So we send our imaging out to specialists in the UK, and they will read the report. They will read the images for us and send us back a report. Because again, they are the specialists, they're at the highest level. Like, whilst we can interpret to some degree, they're fine-tuned for it. So again, it's a huge service that you're providing from that. And the turnaround from a report can, if it's an emergency sort of situation, we can get it nearly, if it's done first thing in the morning, we might be able to get it back that afternoon or evening. But it's usually a turnaround of about 24 hours, which is exceptional considering what it's like in the healthcare system.
Yeah, absolutely, yeah.
So moving on from MRI then, we go to CT. We have this system here. Ours is a movable or portable system. It's the O-arm. We use it mostly, predominantly, we don't use it in surgery. We leave it outside of surgery. This system here is a different one. This is a new CD. This is an exceptional piece of equipment as well. This has a standing portion here, the stocks, where it actually drops down into the floor. So it actually moved the head up rather than the system moving, the horse is moved up and down to allow its head to pass through the tunnel. So CT for us, we use it for head injuries and sinuses. It's very good for upper neck as well. And usually the distal limb, again, very much depends on the size of the animal. If it's a foal or something very small, we can put them under general anesthesia and we can stick them on the table and shove them through as much as possible. So therefore we can get higher up images. But if they're large adult horses, then we are very much limited to what can physically fit through the arm. So the CT is a little bit different. It's not a magnet. It's a type of X-ray, and it generates images around. So it rotates around the actual whole head and then gives a detailed 3D image, which is called a slice. And based on the I suppose the degree of the CT quality, it depends on the image thickness or the slice thickness. And that's a better definition. So for a lot of the time, what we would use is for teeth and sinus issues. It gives a great, especially for pulling teeth. If you have any query over root, CT is far superior. Again, any sort of traumatic injuries to the head or upper neck, head shakers. Again, it's kind of related to the degree of what it can see on a head from a soft tissue point of view or from a bone issue. Any sort of orthopedic conditions in the distal limbs, so you're looking at potentially fractures, disc lesions, any sort of aberrant bone growth or anything like that in the distal limb. Obviously that became quite commonplace with race horses needing to travel down to Australia to race. They had to have a lot of them needed CTs to prove that they were, healthy distal limbs before they go racing down there. Upside of these is for using it for surgery planning. So if you have a complex or very, I would say like a smashed fracture and you're not really sure where the fracture lines are going, this will allow you to get a CT, will give you a 3D read of what's going on and allow you to try and manage or pre-plan where you're going to put screws or plates, etc.
Another sophisticated piece of kit.
Absolutely. And this, what I would say is this is much quicker. The CT takes a lot, like up to about a minute to take an image. Now again, as I said, you may need to put them under general anesthesia depending on what you're doing, but a lot of the time, most of our stuff we can do standing. And the cost, I would say the cost, it is significantly cheaper than the MRI, but again, they're showing up different pathologies, and so there's, again, you have to bear that in mind. Moving on then to dynamic scoping. So should play, I think. So this is an overground endoscopy or what we kind of call an onboard scope, and that's where the scope is placed into the horse. And it has the horse and the jockey then has on the saddle, there's a saddle pack with the computer, an onboard computer that's linked to the scope. And that can record basically an image as the horse is used to gallop, or for a sport horse, basically in work under a particular flexion of the head or neck, depending on what the reported issue is with the horse. Dynamic scoping is it's quite critical. It's used to diagnose airway problems that are considered only a dynamic problem. So when a horse is exercising, and this is very typical of ones with axial deviation of the aryepiglottic folds, which I'll show you some photos of it later on. Dorsal displacement of the soft palate. Now, dorsal displacements, they will be picked up at rest, or you'll hear it like usually the jockeys are some of the best ones for telling you that they'll hear a horse gurgle or they're making a bit of a noise and then they stop or they cut out during racing. But so you miss about 30% of your horses if you just scope them at rest. You're going to miss a dorsal displacement of the soft palate. And then epiglottic retroversion is where the epiglottis flips back into the windpipe. And that's it's quite a rare occurrence, but you will not see that at rest. That only happens under exercise conditions. So this, as I said, extremely useful for horses that make abnormal respiratory sounds, poor performance issues where you're not really sure what's going on. The horse isn't really making a sound, but he's not working to the best of his ability. Or horses that are taking a long time to recover following exercise. Because again, you have to think about what's going on in the airway. If there's something that's occluding the airway or reducing some form of airflow, that actually significantly reduces oxygen to their muscles, and these horses then can be quite delayed in recovering after exercise because they've gone into sort of a lactic acid kind of state following the exercise.
Mm-hmm.
I'll just see if this video is going to play for me. So this is just one horse, an example of what we see on the scope. These are the area epiglottic folds are in here. This is the epiglottis. This is the arytenoids. This is a horse that's got dorsal displacement of the soft palate, where the palate has now displaced over the epiglottis and we can't see it. So this is why you'll hear this gurgling noise from horses, and then it's back over again. So vocal cords here, you get a really nice shot view of these. These are what we can take out during a hob day. So as I said again, there's the epiglottis, and then it's disappeared again because the palate has gone back over.
Mm-hmm.
So this is something you won't see, you typically mightn't see at rest. So this is why we would perform this procedure galloping.
And I suppose, you know, like the prognosis from these type of interventions, and, you know, what's the outlook for these horses in general? Does it depend on the grade of the atrophy?
Yeah. It depends on the issue that you're dealing with. Dorsal displacement, soft palate, there's a couple of different techniques that we use. I think we've gone back to using soft palate cautery a lot more than doing the tie forward procedure. And the soft palate cauteries, we find we do get a good response to them. Our epiglottic folds, resecting them, yeah, they seem to do quite well as well, and they've got a quick turnaround with regards to surgical healing. And then you're looking at the roarers, which I'll cover because just with specifics to that, they are trickier. And again, they depend on their grading. I would also point out that a lot of the upper airway issues might be more significant for a racehorse than they are for a sport horse because of the degree of the pace that they're going at, the fast pace. They are really, you know, every little bit that reduces the diameter of their airway is incredibly significant and detrimental to their racing performance. Mm-hmm. Whereas a hunter or a sport horse, they're not exercising at that excessive pace for a long period of time. Mm-hmm. So they're able to tolerate a lot more within their airway or up in their larynx region than
and what about, for example, eventers? You know, I appreciate
eventers, but yeah, again, because eventers are going to have to move, they're moving over a long distance, and they're moving at quite a quick speed, especially in some of the tracks where there's a tighter timeline. For sure, this is going to impact them more. Mm-hmm. So what do we do then? Elective work-wise, I'll run through what we're doing. So minimally, this is just a couple of terms, just so that you kind of get just for anyone who's just a little bit curious about these. So endoscopy, basically, we do a lot of work with the scope, or putting some form of a camera in somewhere to help us with surgery for minimally invasive. So endoscopy is scoping a region. So that's where we put the scope up into their nasal passages or their upper respiratory tract. Arthroscopy is then scoping a joint. So we stick a camera into the joint and we take out, and I go through that. Tenoscopy and bursoscopy are basically going into synovial structures. So the tenoscopy is going into a tendon sheet. Bursoscopy is going into a bursa. So like your navicular bursa, which is a structure like in the foot. Laparoscopy is putting a scope into the abdomen, and then thoracoscopy and is into the chest, and then cystoscopy is going into the bladder. And laser is actually, that's what it actually is, an abbreviation or for what it actually stands for. So that's just very quick overview, kind of some of the terms we
terminologies,
use.
yeah. And I can see there's been a few have joined us since we actually started at the beginning. So I'll just give another warning out now for anybody for upcoming slides that there might be a degree of graphicness to the imagery, etc. So if anybody is shy of that, stick with the audio version.
So arthroscopy or laparoscopy, why do we do these? These are minimally invasive techniques. The advantages for them are you've got decreased soft tissue trauma to the region. You've got a lot more, because of that, then you've got the knock-on effect over the add-on effect of that there's a reduced post-op pain and morbidity resulting in that.
Mhm.
And because of that, then again, you're getting a faster return to function, means they get back into work, they're eating better, you can kick on quicker with them. Other issue is, or other advantage to this is that you're putting a camera in there that's then magnified up onto a screen. So you've got a much better surgical viewing, especially when you'll see when you're putting in for into the abdomen that the scope is very long, so it's something, unless you were going to stick your head in its abdomen, you won't get that visualization.
Mm-hmm.
Disadvantages, obviously, then for something like this is it requires specialized equipment, which means more money, and it's a specialized technique, a skill, to be able to use these. Our cameras, they're not end-on cameras. There's a slight angle on the lens, so even rotating yourself, especially when you're looking at legs upside down or abdomens upside down, takes a little bit of skill.
And typically, what are you looking for here, and what sort of cost point are people at with this kind of work?
It changes, obviously, again, depending on what we're doing. Arthroscopy, we try to be competitive, but again, the equipment and that, you're looking over €1,000, and depending on the joint you're going into, it will change, or what you're doing in the joint. And I will touch on that as well through these, but and then again, if you're doing multiple joints, you have to, obviously, we don't charge the same price if there's a set price for one joint. We obviously do a much discounted rate to do another joint on the horse at the same time, because it's under the same anesthetic. Mm-hmm. And it'll be using the same antibiotics, same treatments, etc. Other disadvantages to these techniques is that, I suppose, you don't have that tactile feedback that you get when you actually physically have your hands on something. So it can be, you just have to get used to that. You don't have the same depth perception. Again, this is something that you will learn, or you're trained to do during your residency program. And then we do have a lack of very much specific equine equipment. We either tailor it, we're using it from small animals or from human medicine. So that can be a little bit problematic. Mm-hmm. So arthroscopy, then you were just asking about them. So what are we doing? The routine kind of stuff that we do, I suppose, are OCD lesions. So these are chips. You'll hear people talking about chips. There's one here on the distal bone here. You can see this little fragment there. That needs to come out, because that's going to cause irritation in the joint. This is a video of a stifle from last week that I was in, just showing this is a probe sitting in, and we're just feeling out, basically delineating in around the lesion itself, and just that probe is just used there to basically get the margins there before we start taking it out. Mm-hmm. So OCD,
typically you're doing this kind of work with what type of horses?
These would be sport horses and race horses. Typically the screening sets are done in young animals, so you're looking at your weanling yearlings, and I would say thoroughbreds are doing them much, they're kind of gaining. We'll do screening sets on them, and we'll take these lesions out for clearing them up from a radiographic point of view for sales. So a lot of them are done, yearling age, or getting ready for the yearling age. And sport horses, they'll do, a lot of people or breeders will do, again, they'll do them probably maybe a little bit at a slightly older age. They might start spotting them, or doing screening a little bit older. Other issues would be, I suppose, we'll see older animals that are getting ready, they've been broken, they're back, they're ready to sell, and then they do the screening rads to get them to see about before sales, and then we'll do them at that point when they're getting clean up.
Are there risks to these interventions? Are there?
Yeah, absolutely. There's always risk to these. And any surgery that you do on a horse is not free from risk. The significant one for us is that these horses undergo a general anesthetic. That means they have to be, knocked out to do it. They're on their backs, and then they have to be recovered. Whatever about weanlings and yearlings, we kind of try and stay in with them, hand assist them, to some degree, to stay as safe, with being as safe as possible. Excuse me, but our larger animals, that's 500 kilos plus of an animal waking up from an anesthetic, doesn't know where they are, still basically can be coming round from the anesthetic, can be a little bit ataxic, can be very, very sensitive to noise and light. So we do try our best, there's sedation protocols when they go back into the recovery box to try and minimize so that they don't get up too soon. Then we can do rope assisted recoveries. So we tie a rope, attach it to a special head collar on their head, and we have a rope on their tail. and that's to help them to get up and try and keep them steady on their feet. And again, for anyone who is in at the tour around the clinic, you'll see we have very well padded boxes then as well to try and cushion them if they do fall or hit the walls or anything like that, you know, it's well padded. But unfortunately, like, you know, they are big animals and there is still risk. So some of the concerns would be obviously fractures in recovery, catastrophic fractures. Or we have had, you know, like you do get ones that have a very bad reaction to the anesthetic itself. Other reasons for taking these chips out, I should say as well, would be lamenesses that they're actually causing a clinical problem. So these will typically present later in their age, when they start to work, or, you know, they're starting to do their prep work for sales, and the joints will start to fill or get very fluidy, and that the horses are physically lame from them. But that's when we'll go in to take them out as well. Other issues, so this is another one. This is just a simple little chip up here at the front of the fetlock joint. Third carpal bone disease, something we kind of see more in race horses than sport horses. So this is a lot of sclerosis here. Sometimes we go in again just to try and clear up some of this and help that along. Or sometimes, again, it depends on the client and what they're doing. Sometimes we just you tailor the training program for them to try and help that or alleviate that. Soft tissue injuries then we'll also go into, and that's manica flexoria tears, deep digital flexor tendon tears, and annular ligament desmitis. Those are the three big ones for sport horses. They would be the kind of, you know, we don't see them I won't say we don't see them in race horses, but it'll be, you know, more likely it's your sport horse clients that are going to come in with issues when the tendon sheets are filling up with fluid, and we're going in and we're looking at something like this on them.
You might need to explain, well, some of the terminologies there.
Yeah, that's no problem. So the manica flexoria is basically a tissue that runs around the back of the tendon. It runs off the superficial flexor tendon, and essentially it wraps around the front of the deep digital flexor tendon. If that tears or gets any kind of way inflamed or strained, it starts to cause a lot of inflammation in the tendon sheet, which is it runs down at the back of the cannon and over the back of the fetlock and down at the pastern. It can become quite inflamed there, and the horse can get quite sore. So if that tears, you need to go in and actually we cut it out altogether. And remove it so that there's no longer that inflammation or that constant tearing and straining of it.
And does that impact then on future performance ability?
No, they typically do very well afterwards. They do need time, but no, the sooner you treat that, the better before it causes this. If you get a chronic issue here with this manica, you can actually get this can cause a secondary issue here with the annular ligament, and the annular ligament wraps around the back of the fetlock. I would the easiest way to, I suppose, equate it to a person would be annular ligament desmitis would be something like carpal tunnel syndrome, where they get that tightening, and you basically need to release the ligament to allow to get rid of the pressure build up in the back of the tendon sheet.
I think I need to recruit you, Anne.
And
for my own purposes.
Yeah. And the DDFT, is a deep digital flexor tendon. So they can get like longitudinal little tears, and you might have to go in and try and clean them up a little bit. And they're kind of, I suppose, the biggest overall of why we put scopes into our joints. The other one then, from an emergency point of view, would be a septic joint, where, you know, there's a wound that communicates directly with a joint, and that's contaminated. So we go in with the scope to try and flush them out and clean them. That's the video playing again. I've taken these from an older study, but this is kind of a newer technique that's come into the clinic in the last few years, and in other referral hospitals around the world. And that some of these OCD lesions that we take away have, you know, they're pretty big flaps of articular cartilage. So it's been shown that in younger animals, if we can avoid removing them altogether, we can actually pin them down with these absorbable pins and leave that, and it'll basically nearly reattach. So that leaves the articular cartilage. Now again, it's becoming more, I won't say common compared to taking those fragments out, but it's building up. But again, with stuff like this, you have to take into consideration the costing. These are very expensive compared to your routine OCD fragment removals. Like roughly you're probably looking at an extra €1,000 on your bill. And at the moment, you know, is the outcome really superior to what you're getting? We don't have enough data, I would say, at this point. You know, there's not been a huge retrospective study in terms of performance outcomes, etc. However, they look like I would say they look excellent on your radiographs and that for sure. And I'm not knocking it, but it's something that, you know, I personally myself have had a couple of clients where their patients or their horses would have been prime for doing this, but they're just, it's from a costing point of view, it wasn't cost. It was cost prohibitive to them.
That's an important part of the
it is,
conversation.
And unfortunately, that is sometimes, you know, some of these new techniques are fantastic, but unfortunately, from a costing point of view, it's just not sustainable, especially when you're looking at fine margins with your clients and that. So you just have to be very realistic.
Yeah. I guess it's like anything, isn't it? When something is new, it's more expensive, and then, you know, exactly. in time that may change.
Exactly. Laparoscopy, then moving on to that. So the big ones that I suppose we do in our clinic for these would be ovariectomies. So where you're taking out either a tumorous ovary, or if you've been requested to do a bilateral one for mares that are really, you know, have very bad behavioral issues, or you
so in other words, on both sides, you mean? Yeah,
sorry, bilateral, taking out both ovaries, or you're looking to create a teaser mare, or even for the recip mare. But I would say bilateral, I've not really done too many of them. I've not done any of them in Ireland, actually, from a bilateral point of view. The reason I would do them is for taking out a tumorous ovary, because it's causing a negative effect on the other ovary within the mare, and the mare is not cycling properly.
And so therefore, by doing that procedure, is one having a positive fertility outcome potentially for the mare then with the other?
Yeah, absolutely. So taking out I have one scheduled this week. The mare the issue is the mare is not able to cycle, so they can't get her in foal, because when it's tumorous, it stops the other ovary from functioning, and it becomes that other ovary ends up shrinking, and you end up having the mare won't cycle for you. So yeah, and being able to do this in a laparoscopic technique, it's minimally invasive. We avoid having to put the mare on the table. She doesn't have to go through general anesthesia. Now, there's always a caveat: if the mare is dangerous in the stocks, then, you know, health and safety first. If we can't physically do them standing, then they have to go under general anesthesia to be done. But I would say
it seems logical. Yeah. And that video that was playing there a second ago, and
this one.
Yes. So
that is the ovary.
Yes.
So we use
that's huge.
That's huge. So that's a tumorous ovary. That's massive. Like that was, I won't say it was as big as my head, but it was, I think that measured out at about 1 kilo when I weighed it. So that had to come out. And this just that's not just a random bag. That is a sterile bag. It is a plastic bag, but it is a sterile one that we use so that we can put it safely into our abdomen to catch the ovary. And then we put it up to the body wall, and I just extend my incision and just tease it out as much as, so I take it out through as minimal surgery site as possible.
Yeah, it's amazing what you're able to do. Yeah.
Uteropexy is then another reason for doing laparoscopy, and these are for mares that have the uterus is sitting very ventral, so it tilts down. And they're not able to clear properly from their uterus. So you see this in older mares where they've had quite a few falls and they start to drop quite a bit. So the idea of the laparoscope is to go in, and you're basically moving the uterus up into a more ventral position so that they're able to clear normally. It's called a uteropexy. So it's basically we call it imbrication. So you're stitching the mesometrium. So you're pulling up the uterus and back up, and just basically tightening up that region. And this is just a pre-op where you can see she's quite sunken. Because if you think about it, the uterus can be quite heavy depending on the time of season. So when that's tilting down, actually that'll pull her anus and her perineum back in. So once she was corrected, this mare actually, you know, their conformation corrects quite a bit as well, which is excellent.
And I suppose, you know, things like urine pooling and all of that, the rest of it is a consequence to the former.
For sure. Now, if this is they don't, just because you might necessarily use that technique for all of those, doesn't correct you know, some, but yes, for sure, there's a knock-on effect with a few of these.
And like 2 points, what's the outcome for those procedures? Is it generally good? Is it generally positive? And what's the kind of cost point of those kind of procedures?
We currently, I have myself and my old practice that I worked in. We do have a paper in for submission, or being prepared for submission to a journal on this. Now, it's only on a small case series done in Ireland, but there's actually very little data published on these mares for the uterapexy technique, unfortunately. But any kind of, the two that have been produced, Schumacher, Brink and Schumacher were the two that brought out this technique a few years ago, and they had a good outcome with them. But then small case series and could do with a larger case series to find. Plus, it would need a lot more follow-up data. You'd need a couple of years to see, did the mares go on foal that same year? Did they carry the foal to term? Was the foal born alive? And did she come in the next year? Rig castrations, we do them all knocked under general anesthesia. We don't do it laparoscopically. Yes, you can, but the typical ones that we would get presented are yearlings. They're, I would say, mostly not necessarily unhandled, but they'd be quite unhandled. And I wouldn't be comfortable again putting them into the stocks. Plus, I can do them probably significantly cheaper and quicker to do them under general anesthesia versus doing them standing with a laparoscope. So that's why we don't. It's never really taken off in the clinic. So that's why. And then we'll go moving on to transendoscopic laser surgery. So in a nutshell, that's where we put a laser up through a scope that we use in the airway. It's very much a minimally invasive technique. And the upside to doing this is that we can do this all through a standing procedure, just with some sedation and local anesthetics splashed around the larynx. One way, so this is one type of airway issue I was talking about earlier on that you see with the dynamic scope. This is an aryepiglottic fold. This is axial deviation, where the AE folds are pulled in this way. So they should be sitting out here, but they've actually come in here. And when they come in here, I know it doesn't look like a lot, but this causes turbulence in the airway, and this reduces airflow.
Again, I like it with all of these. It's when they're at stress of exercise that these things become more of an issue. You
won't see this at rest. This is a dynamic issue. And then we come down here, and this is just one post. What we've done, we came in and actually lasered these out, understanding sedation, so they were removed. This is it healing, and this has also had a hob day done. So we've done. So, and what's the recovery time for these, Anne? Like how long post procedure? And we give these kind of about 2 weeks off. You know, they go home with topical steroids, so they're getting to try and settle down all the inflammation from the laser. But because they don't have an open, a traditional laryngotomy site underneath, these heal quite quickly, so you can get back to work with them. You know, it's a quicker turnaround, I would say, for them. And I know I keep asking you, but you know, where is one sitting price point with these kind of procedures? It's kind of questionable. Like sometimes these kind of vary. Like for this is a relatively straightforward procedure. You'd be looking at less than €1,000 for doing these. You know, they're standing quick. I would normally warn a client though that sometimes you have to take into consideration the amount of sedation that you might be needing for a horse if they're very, very bad tempered or just very fractious. And it's a sedation that sometimes really stings us for trying to keep our costs down. But for me, you know, you're looking at in around the sort of I want to say €500 kind of if you're doing a knockdown hob day, in around that. So like this is a very specialized technique. Now, whilst it can be quick and you avoid doing the knockdown, you know, again, you're kind of have to pay for that specialist service as well. But they are this is still significantly cheaper than say going and doing your tieback procedure for a different technique for a different issue. Other stuff that we can treat with the laser standing are subepiglottic cysts. So this is a big cyst sitting under the epiglottis there. So this
It's not very pretty looking.
No, and causes a lot of issue here, you know, with swallowing and also from a racing point of view. We see these in very young draft foals can be seem to be a bit predisposed to this within the first couple of weeks.
And tell us, Anne, like when these, you know, when you do these kind of procedures, and in this scenario, like we say that the one that was done there in the bottom right, like, is there a possibility of reoccurrence? You know,
it's a good question. No, certainly for the AE foals, no, because they don't grow back. So if you remove them, they're gone. Now the other thing to remember is that you've there's airway dynamics. There's a lot of biomechanics to the larynx, that is very hard to understand especially when you put it under maximal exertion. So, you know, the AE folds are there for a reason. That's, you know, they were created, or they're there through evolution. Mm-hmm. So, you know, you are obviously changing. You have to be changing the dynamics of the airway by taking them out, and that has to be taken into consideration as well. Now, what the true result of it is, I'm not going to say that I know definitively, but changing something in the air, like taking out tissue that's supposed to be in the airway, will cause a knock-on effect to some degree elsewhere. Now, it mightn't be detrimental, but you are changing airway dynamics by removing some of these tissues, and that is something to keep in mind, especially when we discuss about it. If you do a tie back and you take out the left vocal cord, now it's been shown that you can then cause, by changing the airflow running through the airway, you can actually cause a knock-on effect that this AE fold starts to pull back in because of the airflow coming through. And that's something that has been shown to occur following these in some of the tie back procedures. So,
there's another question in here from another attendee. Do you have an opinion on whether there's perhaps maybe an overuse of tie back, in the sense that you know, breeders or owners might believe it to be an advantage for selling their young stock, or the outcome of it an advantage for selling their young stock?
No, I wouldn't actually, because the tie back procedure of all of them is the one that you can always spot has been done. If you scope an animal, you'll know, like, because there's no where you're doing that is this tissue here. This won't move. It'll sit in a static position, and it'll be asymmetric and asynchronous. It won't move at all, so it'll be asymmetric to the contralateral, to the right side. Mm-hmm. So if you get, you know, even at a very basic 2-stage vetting where you have your horse scope, the vet will or should pick up on that procedure being done. Mm-hmm. I do think that race horses, I think a lot of people actually, I think people will avoid a tie back if they can, just because it does come with its own range of complications. You know, that's just the procedure. It's a very, very specialized procedure. You know, there's a lot of intricate anatomy in around there, and you can have, like, some horses will have a lot of coughing afterwards, or persistent coughing. They just don't really tolerate the suture very well. Mm-hmm. And there are not, like, as I said, there are knock-on effects with it. So we don't rush into a tie back unless, you know, it's very much from what the surgeon thinks will work, or the client, mm-hmm, or what they want. But I would actually say we would be quicker to do something like a hob day procedure, especially for a sport horse. As I said earlier on, like, the tie back procedure, unless the animal is completely paralyzed, in which case where that arytenoid sits in and it cannot move at all, it's just sitting right nearly fully midline. Mm-hmm. Regardless of what work that horse does, if it's presenting with poor performance, you know, regardless of whether it's a sport horse or a race horse, that warrants a tie back procedure. Doing anything less than that's not going to work for them. Mm-hmm. However, if it's a sort of what we call a grade 3, where it's not fully paralyzed, it has some form of movement, and the horse doesn't have a poor performance issue, then a sport horse would actually, you could avoid doing the tie back procedure on a sport horse. Mm-hmm. But if it was a race horse and you wanted it to at least have a chance at racing, then you need to do the tie back procedure on them. Mm-hmm.
Okay.
Other
So
things
I'm just alerting you that we're at 26 minutes past 9. And we lost a little bit with the interaction with the thing, but I'm just saying that, you know, going forward, maybe pick the procedures that you most want to give.
Yeah, absolutely, that's no problem. So we go through, this is again just for, because we talk about, this is sort of the laser, this is doing a laser hob day procedure standing. So this avoids the traditional hob days where we knock them down and they have the little the laryngotomy underneath. This avoids that technique, and this is what you're left with here. So this is one I actually would have, this is where I know this video, I was doing this up in UCD when I was a resident. And this is the after effect of it then as well, and that will settle down. That was the next day.
Okay.
So upper airway issues, recurrent allergies. So this is where, this is a dynamic, this is a still from a dynamic scope. This is where you get complete collapse of the left side. So this is doing nothing, it's not functioning. So this is a horse that warrants what we would recommend a tie-back procedure. The bilateral, I've already discussed there about them. Dorsal displacement of soft palates, I showed you on the dynamic scope earlier on. This is what a normal larynx looks like, your epiglottis, the two arytenoids up here. This is when you get a dorsal displacement, so that's the soft palate. It's sitting over this tissue now. And that causes this, where you get your gurglers. And then my thing to talk about with these, I suppose, just moving forward, just from my own point of view, my own little plug, is that for these roars and whistlers, there's a couple of different techniques. We talk about hob days to basically try and remove that noise. And that's very much we use for sport horses or race horses that aren't too badly affected. The tie-back procedure, as we've just discussed, this is one that I started doing back in November. And it's a reinnervation technique where you're taking a nerve off a muscle down here, and you're basically transplanting it. So you cut it out of the muscle here and you move it back up to the muscle that is no longer functioning that's causing the tie-back issue, that's causing the left-sided hemiplasia issue. And you basically stitch that nerve into the muscle, and the idea is to try and get it to reinnervate that muscle. I've had success with this technique, which is great, because it's very much in its baby stages here in Ireland. Up until November, I think any other clinics that were using it were getting Fabrice Rossignol, who wrote the paper on this. He was coming over from France to do it, and I think one of the surgeons up in Glasgow or Edinburgh were coming down as well. One of the guys were being flown in to do these. So
where in the body is that visually? Where are you taking that from?
This is just at the back of the jaw. So this is the jaw here.
Okay.
So it's the exact same surgery position for the tie-back procedure. And the reason, so the upshot of this is we can do these in younger animals. That's kind of what you need to do. Do it in the young horses, because these need a lot of time. You have to remember that nerves take time to regenerate or reinnervate. So these can take as little as 12 weeks, but they could take up to 12 months. So these are ones, this surgery is kind of reserved for yearlings that are scoping badly or making a noise, but that you want to get, that they have time for this surgery to potentially work.
Okay.
And you cannot, the other thing is, you cannot do this procedure if the horse has already had a tie-back, because the tie-back is done through the same incision, but you'll actually end up cutting or damaging that nerve during the tie-back procedure, that you won't be able to use it. And this is just this particular horse. So this is what he was looking like before the surgery. So this was making a very bad roaring noise when he went into the lunge arena. Video of him now at exercise. So at gallop, he's making no noise, and he's now got full function of his arytenoid. It's pulled right back up. So this horse is actually, he's got full function of this arytenoid. He's not making a noise, and he's able to exercise at maximal pace, and they're very happy with that and how he's responded.
Yeah, it's much clearer to see it on the still image at the end. Yeah,
it is. Yeah, exactly. This is just for epiglottic entrapment. You don't really, again, it's just minimally invasive techniques for doing this. Lameness, first opinion and second opinion. So again, it depends on your own vet. First opinion stuff we absolutely will look at as well, and second opinion stuff, again, varies depending on where, what you're being sent in for, So feet, tendon issues, potential like the likes of pelvic fractures, suspicious about wobbler disease, or wobbler syndrome, I should say. Anything like that. Like we look at everything from a layman's point of view. Dental work, my own favorite. I do. So again, going back to minimally invasive, so I do a lot of dental work. It's how I was trained in UCD under John Mark, who's the only boarded specialist in equine dentistry in the country. So he trained me to, I would say, a fairly good level. Basically, we brought in this kit when I arrived last year, and it's a drilling technique to take out teeth. So if the tooth fractures or breaks, oh, that's not a very long video, but anyway, if the tooth breaks, it means that I can drill in a little hole into their cheek, and basically I screw into you screw a tap into or screw into the tooth and hammer it back down. So it's still an oral extraction, but it's bypassing having to do the repulsion technique, which used to be where you get a big pin over the tooth root and hammer it down to a flap, and which causes an awful lot of peripheral damage to the soft tissue and to the alveolus. So this is a much finer technique, very specialized. It is, it's not a simple technique that's got its own complications, but it is something that is it's certainly an advantage.
I suppose a lot of people don't maybe think about, the consequences of
Exactly. I think people, and I do think it's the veterinary industry's own fault for not. We should have kept sort of, people don't like, vets. You'll ask most vets and they really do avoid going anywhere near teeth. I think the newer graduates coming from certainly UCD, because John Mark is up there and he is practicing at such a high level of the dental work. I think the students and new graduates would be much more would be much more informed on dental work than what I would have been when I went back to do my residency. I don't think I'd ever floated or rasped teeth on a horse, and I was 3 years out nearly at that point. Fractured jaws, we see plenty of them. Parrot mouth surgeries, yeah, we do them. We try and avoid, these are obviously, there's an ethical for anything. You shouldn't be doing this in breeding animals because it is inherited and it's passed down.
Absolutely, yeah.
And then endodontics, something again I did up in UCD. I don't have the equipment to do it down in Fethard, not yet anyway. But I'll give you a plug for UCD for that one, because John Mark again does that. That's doing fillings and stuff like that in their teeth. So actually reasonably quite straightforward, but it's a very specialized technique again.
And again, the risks around this kind of work.
No real, for endodontic therapy, nothing really. Like it's very minimally invasive, provided it's done on the right case, and for the right reason, then it's very effective. Parrot mouth surgery, they can be tricky. You need to be doing these, if you have the right foal to do it on, you're doing them around 3 months of age. I would really stress to clients not to be leaving these any longer. I like the bracing technique if I'm going to use them. So you put in braces, almost like yourself. Like, I had there's wires wrapped in around here, and then you put a white plate on, and that protects that. It just stunts the growth there to allow the lower jaw to catch up with it. It doesn't come, that can be tricky because the wires can break. The foal can really annoy the mare because he's got a brace and then a bite plate on with this hard kind of acrylic around, so that can actually hurt the mare's udder. So they just, I
was going to say, it must have impact.
Yeah, so sometimes we would recommend they wean the foal off at that point and manage it that way. But they do, if it works, they do very well. I'm very keen on this. If I'm going to do it, I'd rather try this than waiting. I've recently done a couple of these osteotomies, and there's a lot of collateral damage, I think, to do. It's very aggressive surgery to do over doing the braces at a much earlier age. This is just an example of a wiring technique. Sinus issues, I'm not going to go through that, like that's just a workup of them, but these are kind of just different things we do. There's the CT, a kind of a still from CT, why we would use this. It gives this beautiful image here of the skull at one slice there.
But again, I suppose, the issues with the sinus can be quite impactful on the horses.
Yeah, for sure. They absolutely they can really, you can imagine if you're going around yourself when your sinus is full, you're not in the best of form over it. So especially, and my one thing for clients, I suppose, warning about sinus issues, having dealt with them a lot, I think a lot of, just generally, even vets and that would think that, okay, well, we've pulled the tooth that's causing the sinus, great, the sinus infection, absolutely brilliant, or we've removed the cyst that's causing the sinus infection, excellent. Why is the horse still draining after surgery? And I would stress that a lot of these, you've got a lot of bacteria, etc., in these, especially the chronic ones. They can be, and if they've been on a couple of courses of antibiotics, they can become quite resistant, and they can be really difficult to get cleared. So, my old boss, so John Mark, used to tell me that, and again, I think he was trained when he was trained by Paddy Dixon up in Edinburgh. Their term was, their question to a client is, like, what is the difference between love and sinusitis? And, sinusitis is forever. That's what they used to say. Because it's just so different. It is something that I would always, I'm very clear with clients over that, this is not a quick fix, these issues. But if you can get them under control, then yes, I do think it's the horses are usually a little bit more, they're more tolerant around everything. Reproductive surgeries, I suppose, just for considerations for all clients, is the breeding soundness exam. Before you go rushing in to do a surgery on a mare for a reproductive point, get a breeding soundness exam done. Your own vets will do it as well, but it's certainly, there's no point us going and doing surgery. As much as I love doing surgery, there's no point me doing surgery on a mare if it's unlikely to restore fertility to her. There's no point me going in and say doing that uteropexy if the uterus if she's never going to be able to carry a foal, regardless of whether I do the uteropexy or not.
And I think, to be honest, I think, like anyone that's considering investing money in mares, whether it's, from the perspective of a surgery or just from the perspective of actually breeding from them, or they're purchasing a mare or whatever, the key purpose that you want them for is actually to be for their fertility to be good, and to not impinge on your costs any more than necessary. So I do think those breeding soundness exams are such an important part of the whole picture.
Yeah, absolutely, because it'll tell you a lot before you go anywhere jumping the gun, and like I said, doing potentially an unnecessary surgery or costly procedure that's not going to, at the end of the day, benefit you from a point of view of getting a foal or a live foal out of this mare. So some of our stuff that we do for perineal confirmation, obviously, is the big thing. Like, a lot of people are for pneumovagina, where they're sucking in air. Caslets, like your own vets, like all your reaper vets, they'll all do them. To be fair, they'd be much better at them. They'd be slicker at them than me, because I do very few of them, because obviously people don't send them in.
So you're talking here about the stitching of the vulva, just
sorry, yes.
Keep the terminology bit for everybody.
Yeah, just putting the stitch down here, and that's just to try and help stop air sucking in, and that's for, again, mares with a little bit of a poor confirmation at the back.
Yeah.
Going into the more, so coming in again, now there are vets, not necessarily a referral job. There are plenty of vets that will do this, the GADS procedure, and this is again just trying to restore that confirmation here, this perineal confirmation. So you're just trying to increase the thickness of the perineal body and try and give it a more vertical, the vulva, a more vertical appearance.
How successful is that, Anne?
That's very successful. It's a good technique. Again, I would sort of stress, for some of it can be down to mares in very poor condition. So it's not just a surgery that needs to be fixed. You need to tell clients, okay, well, the mare might look very sort of what we call cachectic, where they're very poor body condition, emaciated, nearly, like that's, you're not going to be able to fix them. Like they'll need condition as well to try and improve that. Urine pooling, another issue. We do urethroplasties, or what they call a urethral extension for these. Again, that's going in and just you're dissecting tissue in at the vestibule, and you're pulling it over and basically extending the urethra further back, so they don't have this. So the urine only has one way to go, and that's out the back, as opposed to going cranially down in, or going forward down in sitting in front of the cervix. And pendulous uteri I spoke about, same with tumors.
And just before you jump on there again, you know, like for those who are considering some of the procedures that you mentioned there, like the GAD and what have you, like are these expensive procedures to undertake? Are they?
The GAD's procedure is, these would be cheaper now than doing the likes of your laparoscopy or removing ovaries, for sure. You know, urethral extension, it sounds very simple, but it's a very, very tricky procedure to do. It's a very delicate one. And it is one that comes with its own complications, like, you know, in terms of wound, like breakdown as well.
So are you like, would you take into account then with these kind of situations the age of the mare and so forth as well, and in you know the merit of undertaking these procedures?
Yeah, for sure. If the likes of your urethral extension, or maybe even your laparoscopy, and that, you know, if the mare is potentially only going to have maybe one more season out of her, you know, realistically, maybe it's not really worth it. The GADS procedure, I would still use that on an older mare. Absolutely. I think it's a very good procedure. I'd be very inclined to use that. Now the urethral extensions are excellent as well. But I think it's all these procedures you have to take into account the age, like realistically, what is your goal next year with the mare, etc. You know, hernial injuries, you'll see these all now this time of year. These are from foaling injuries. Mostly
these are the ugly stuff that shouldn't happen in the first place.
Yeah, this is the one that'll put you off, especially if you're pregnant and looking at what the foal's just done to a mare. So these are typically primiparis mares, so that's the first mares, maiden mares essentially, and that's because they're what it's called the annular ligament, which would have been the remnant of the hymen, is still quite taut, and the foal will catch it with his toe or can with muzzle even, and it would tear it. And if someone's not there to, and if you know, usually good study managers and that will see that this, you know, something like this is happening, and they'll go in and they'll kind of tip the toe back down or replace it correct.
But I suppose also mares that maybe have had the castex or the stitch in the vulva and that hasn't been opened.
Yeah, they can tear quite badly back there as well. So what this will cause is when the toe comes up, it will push through, and then you'll end up. So these are varying forms of it, where you've got where you've got complete communication now between the rectum, and then the vestibule. So you've just got feces now sitting in the vagina, the vestibule, and in around the cervix and the uterus, which is obviously, that's not good for them in terms of infection, and even then getting them clean from a breeding point of view. And this one is, you've still got some degree of a rectal wall there, rectal shelf. So what we call is, can
there be good outcomes for these, Anne?
Yeah, absolutely. There are, like, and these are ones I really do love doing these surgeries, because every time they're never the same. You never get one, like they're never simple down the middle and you go, oh great, it's down the middle, all I have to do is dissect, my dissection is going to be even on both sides. They always tear in a kind of odd, depending on how the fold tears them. So I do find them, actually, I do, because I always have to go in and think, like, you don't go into autopilot when you're doing these. I don't find anyway. They do, look, again, the really big disruptions can have problems. They can break down, but I do find that, like, I do really enjoy them, and I do think when they work, they work excellently. And just because it happens once doesn't necessarily mean it's going to happen again to the mare. Like I said, second degree and third degree is just a difference between, third degree is this one where you don't have any wall at all, and this would be considered second degree, where there's still some wall there, but you've lost the back part here. For these mares, we always tell clients you need to give them 4 to 6 weeks before we go anywhere near these, and that's to let all the inflammation and that down. If you go in too quickly, it'll just break down. You need to let all the inflammation and the sort of scarring and all that just settle, and let the muscles and everything settle down, and you go and do them. So unfortunately, this can be quite frustrating for mares that are, obviously, if this happens very late in the year.
Oh yeah, you're
keeping on, and it's very tight to get them
time. Yeah.
And cervical lacerations, like we see these obviously in foaling. These actually, you'd be surprised these happen quite regularly in normal, what is perceived as a normal foaling or an uneventful foaling. These are seen in older mares, and typically these get picked up at the post foaling exam by your vet. We do surgery on them, but question about, you know, the cervical laceration when you repair it, you know, you're getting some degree, like you're getting fibrosis there. That cervix is always going, you know, realistically they're more than likely going to tear again, and something to keep in mind. So these are, I would be very cautious about, you know, for these going forward. You know, these are definitely prone to re-tearing.
Okay. I'm getting conscious of time now at this
Yeah,
stage.
I'm just, that's a summary, that's just a summary going through it for the skin lesions. We do sarcoids, squamous cells, melanomas. So these are just all different types of tumors and that I've seen in the last
weird and wonderful stuff. Yeah.
This is just, so for us, what makes it kind of a specialist procedure for us is that we do laser excision is one way of doing them, to remove them, and electrochemotherapy is also. And these two are the ones we use in the clinic because their potential for stopping regrowth is up past 75-80%. If you remove them with a blade, you have about a 50 to 85% chance that they'll come back. So that's, you know, so that's why we do laser excision or electrochemo. This is just one just showing it's been done. So that's the shock then. So that's running a current. So this has been so this horse has had a local anesthetic, so you can't feel it. I know it looks like you can feel it, but it's because you're running an electrical current, so they're twitching.
Okay.
So we have injected cisplatin in around here, and then the electrical pulse runs through this, and that actually helps the cisplatin diffuse into the tumor's tissue.
Okay.
Okay, that's one we do. This is just post laser excision. So that was one. Angular limb deformities, big ones that we see, especially now this time of year with the foals. Ideally, if you're going to send ones to the vets or to ask your vet, yes, whilst you can sort of see here, okay, I'm pretty sure I can see a slight valgus at the knee here, but I'd be more querying what's going on with the fetlock. But the best way to assess these is get your animal to walk away from you and walk back towards you. So ideally, if you're going to send this to your vet, you want to video the foal walking away and walking back in as straight a line as possible and on good flat surface, because then you'll be able to assess, because you're watching the flight of the foot, and that'll let you know how off are you with the joints, like, you know, in terms of line. Now, with regard, like, obviously if it comes in looking like this, you don't really need to watch it walking. You're very certain you know what the problem is.
I think with these as well, it's about having that good communication and relationship between farriers and vets and
absolutely. So this one in particular, this is a young foal that I was actually just being asked about there the other day. So this one is too young to do anything with the knees, always querying about the fetlock. It's still got quite a bit of time to go, so I've advised that it gets a natural trim with the farrier, and then they're going to send me a video in about 8 weeks when it hits 8 weeks old. See whether, but more than likely this will actually correct itself with time. It just needs a bit of time. And the main thing is to know the art of dealing with the angular limb deformities is deciding what can wait and what needs to be surgically intervened with. Obviously, we have a timeline with fetlocks with regards to growth plates, same with the knees. So we're doing these, you know, before 3 months. You want to do these, you know, you get away with knees later. So you just, again, knowing when
the closer to the ground, the sooner the growth plates.
Yeah, exactly. They'll close quicker. Yeah. As I said, farrier, a good farrier then will help you with that. We don't really do extensions. Really, we're kind of more focused on if we need to just take down, like, doing a trimming on them. These are a couple of videos, but I don't think, like, these are just some examples of, like, this is one with a very bad fetlock varus of the hind leg.
These are the very obvious cases,
Yeah, exactly. Like, and I suppose most people be able to see the very obvious. The key is the people who are watching them closely. Like, you'll have, like, very good stud managers or people who are in and around breeding a long time. They've great eyes for it. So to be honest, a lot of the time when we get sent in stuff, we're actually, you know, we're told what, like they already know what to do. We'll obviously have a look as well, but 9 times out of 10, the studs or the breeding operations that are sending them in, like they know exactly, they've got an unbelievable eye for these. Our techniques for dealing with these are what we call growth retardation, is where you slow down the growth on the faster growing side. So that's where we put these screws in across the growth plate. And that these are temporary screws, they slow it down, and then we take them out. Once the animal starts to nearly correct, then we'll remove the screw, and that'll stop then that slowing down. And that's another technique for screws. This is another one, a plug for me, that I've started a clinical trial this year at Fethard for contracted carpi. So this is called, it can't extend his legs fully. Started out, used it on 2 foals last year. This is where I'm using Botox injections into the muscle.
Very interesting.
Yeah, it's definitely, it's one, like there's anecdotal talk stuff about it in France, and that's how I heard about it through one of our interns last year. But it's definitely one, I had great success with it. Now I only used it on 2 foals, so obviously n equals 2 is not enough, so that's why I've opened it out to referring vets this year, to if they have any cases, to send them on down, and we'll go through it with them.
These are common issues,
Yeah, these like, again, carpal contractures are a lot worse than the fetlock contractures. They don't seem to respond to the likes of your oxytetracycline. And they're very hard to get right, when you're doing casting and that. And then if you put trying to cast do full limb casts on foals, trying to get them up, they're scrambling on the ground. They need to be intensively managed during that period of time. The Botox injections, I'll just skip on to show you these ones. This was one of the worst ones. This was him before he came in. So as you can see, like, he can ambulate very well, but
he's getting
very contracted.
Yeah.
This was him 48 hours post the Botox injections.
Oh my goodness. And
he proceeded to improve. I know you can still see him. He's a little bit tight through here. The photo didn't come across, but I have him at a yearling stage, and you can't tell he ever had an issue.
Okay.
And so that's one that we're, again, it's a research study, so we don't have, I don't know the data long term on them, but it's I at the moment, my understanding from the use of it in humans, and that I can't see really a downside to using the Botox in them, in terms of versus doing the surgical technique, which is to cut the tendons of those muscles. Which is obviously they need a general anesthesia for. They need, they have to be done. It's a surgery, post-op, etc. Like, this avoids and negates having to do that. And then lastly, I'll sweep through the emergencies, because it's mostly just, we deal with fractures, so pastern fractures, all kinds of pastern fractures. We do these standing, certainly these ones anyway. These are kind of fairly common for us to see. Condylar fractures, different variances of these. We do the non-displaced ones standing. We do our spiraling ones. So this is where you can see the fracture here and another fracture line going all the way up here. We will do these standing as well. We do 2, depending on the fracture type, we'll do 2 or 3 screws down here, and then we'll put them into a half limb cast to provide extra stabilization further up. Ulnar fractures, we see them in foals. We do them under general anesthesia. And then, this is just sort of our prep for doing condylar fractures, and for pasterns, the same idea. We put them up on a special stocks, which gives it a bit more height to make it comfortable for us. We get them prepped and ready and blocked, and then we get them marked out with needles, etc. We all have a slightly different technique to align ourselves, and then we do the standing fracture repair.
Okay.
Again, just different types of condylar fractures and different. This one was a very severe one that we ended up putting a plate on with screws down distally. That had to be done under general anesthesia. This is just an example of one horse with a spiraling condylar fracture, and this is just him the following day in his cast, moving around.
Okay. Now, I suppose, compared to maybe, and I am really watching the time now, but we'll call this in the next 4 minutes. But I suppose the advances and the improvements in this whole area over the last whatever number of years, like, the outcomes for these are much more improved, are they, than where they might have been 5-10 years ago, we'll say.
Yeah, for sure. I would say I won't say we're a little bit, we've kind of gone back, and we do our spinal and condylar fractures, like a lot of papers and that you'll see they'll put them under, like they might do them under general anesthesia, and they might do plates and that, etc. For the spinal and condylar fractures, we avoid knocking them down at all costs, like we really do. And because these fractures are so critical, like the spiraling component, you never know where it is. And even with a plate on and screws on, that fracture line, if it bursts out the top, I had one, we did this horse, actually, we did this fracture repair on myself, and I had the senior surgeon Jer come in as well, just to give me a hand, because it's not one we would routinely do. Nice repair. The horse we had a really good cast on as well. Horse got up really nicely, but put one step on the leg and the leg blew apart. The fracture blew out. Because it's such a force to come down on, a plate and screws.
Yeah.
So we actually, for our spinal and condylar fractures, I said we do them standing as much as possible when we can. We'll do them standing with screws here. And because we don't know where the spiraling component is going up here, it's not safe to put screws in case we put directly into the fracture and then it blows apart.
Yeah.
So we cast them then for realistically about 6 weeks. Now it's a long time in a cast, but we get good outcomes with them.
Okay.
Fetal bone fractures, nothing really to talk about there, and then we do them all, as much as we do them conservatively. This time of year we're seeing C-sections, not too many thankfully so far. Under general anesthesia, usually we're taking them out for something like this where they're severely contracted, or we can't straighten their legs to get them to come through the birth canal.
Often when it gets to the point of C-section, mares have already been under a bit of duress before they've got to that point.
And even getting, that comes with its own issues as well, talking to clients about C-sections, because you have to think about, well, the cost of a C-section, the cost of the foal coming out as well. That's a lot of money to invest. And the mare is under considerable pressure after C-section. She's at a kind of nearly worst state because she's going to be wrecked, tired, having already gone through being, between the dystocia and by the time she arrives to the clinic. Plus then they're in an osteopenic state to some degree because they're of obviously the milk production they're doing for the foal or getting ready for the foal. They're the reasonable high risk of having a catastrophic fracture in their extremities in recovery, even with as much assistance as we can. It can be a lot of effort for them.
Yeah.
Fetotomies, that's where we cut the foal, a dead foal in the uterus itself. We cut the foal and then pull them out sort of in sections out through the
Parents at once, not pretty. Yeah.
No, it's not pretty. It is, I would say, I've never seen anyone like it, like the guys, Dr. Spirito in particular in Kentucky, and Dr. Rogerson, Dr. Hunt, and Dr. Baker, actually, the four of them all, they would have all done fetotomies over there, but I think we don't do it very often here, not in mares anyway. And it's again, it might look simple, but it's very detrimental. If you don't do the fetotomy right, you can absolutely you could ruin a mare doing the fetotomy if you do it wrong. That wire is exposed in the uterus. It'll cut it. That will shred a cervix, and that mare, you'll never get that mare back in foal. That's if it's
we're on the 10 bells now, so I'm going to push you to finish.
And I'm actually 2 slides. I think I'm done. This is colic, so different things we see. This is always a big concern to see this ultrasound when you've got these big loops here. So our colics, we look at either medical or surgical. Our colon torsions, small intestinal lesions, they're ones that are pretty. Colon torsions are the ones, again, we see sort of 3-4 weeks after foaling. Mares flip their colons over. They're very, very violent, those colon torsions. They go straight for surgery. These ones are medically managed ones typically. Wounds, you get all manner of wounds. I don't need to go into it. We will take.
No, but I suppose suffice to say, you can see the gruesomeness of what you can be presented with, and you are able to do a lot of good with some of these, I guess.
Yeah, and hopefully, like, again, you have to be practical. You have to have a really frank. I would say one thing my clients who've met me would say that I can be very blunt, not rude, but blunt with them. I need to be blunt with them over, cost, what do they want from the animal, what is the plan, realistically from a cost point of view as well, where are the limits to where I can go. It's the same with the colics as well. Some people, again, they might pay for when you tell them the cost of the surgery, but then you have to factor in the post-op management, and depending on what you find in the surgery, their post-op management may increase significantly because of the issues. And that I won't go into surgery until I have a clear sort of line with the client as to what I'm doing, because I don't want to put a horse on the table that inevitably I'm going to end up putting down on the table, and the client, even from a cost, it just doesn't make sense. You need to have that very frank discussion with a client. And in particular, colics and fractures, etc., and wounds, the emergencies, that's the time where you need to be very, very clear, because people are very panicked. Their
emotions are high and all of that as well.
Emotions are high, and look, it's not an easy conversation to have, especially if there's kids involved, like ponies, or or emotional attachment. It can be. I do find that very sometimes better with the sport horse and racehorse industry when it's for it's a business. So it can be a bit clearer cut sometimes. And then lastly, our internal medicine, but not least, obviously, our internal medicine guys are flat out at the moment with our foaling units and that. They provide neonatal care, so ICU, so all our little dummy foals or foals that are really, septic or struggling. They normally have leads hanging out of them from every end. Then they'll manage older foals during the year for like diarrhea, rhodococcus equi are kind of the two big things that happen to them that need management. And then for our adult horses, you're looking at poor performance workups, so cardiac workups, respiratory workups, and then gastroscopy as well. And that kind of sums up internal medicine, like everything that they'll kind of cover everything else. And there's a collaborative effect there. The poor performance stuff can be stuff involving obviously surgery, but obviously then we have other issues. We talk to medicine, so we work as a one team as such. And I'm done. I hope.
I have to say, Anne, I mean, I hate putting pressure on anybody to finish out a topic, because
I could have sat here and talked for hours.
So much, and to be honest, there's probably any area of that we could have spent an hour of itself.
Absolutely.
Absolutely. And I suppose it was never the intention to get into the absolute nitty-gritties of any of the areas of what you've covered this evening, but it has given people a very good flavour for the lengths to which you guys go to in what you do down there. You can maybe kill your presentation there for a moment before we finish out. You stop your share there, and you can turn your video back on. We'll chance that now at this stage. So look at a couple of comments in there, appreciating the share that you have contributed with us, and the explanatories that you've offered and all of that. And like I say, I'm sure yourself and the other colleagues that you have down there are, you're there to serve and to help people, and to converse with people when these. Sometimes it's like you say, it's when they're at their lowest point. When people are at their lowest point, and when animals are at their lowest point, is when they come to your door.
And I suppose when I started, it's very hard as well. When I started back in Fethard, I didn't have clients. I was very much new to back being at the clinic. So unfortunately, a lot of clients, the first time they meet me is actually on their worst day. Or I'm giving them some of the worst news. So at that point, it's tough. But as I said, I think that is one of our things that we have to be offering as a referral centre. You need to be able to, obviously all vets, we are there to advocate for the animal or patient and what is best for them. But equally, I won't blindly lead a client down the garden path over something. You need to know where the line is. And I certainly from surgery in that there is some stuff that, yes, in theory you could do or try, but that does not mean it's just because you can do it doesn't mean you should do it. And I could talk all day about the likes of fractures and stuff like that. like our big thing for like horses are just biomechanically so different to other creatures that we face such complications with them with regards to laminitis in particular is a massive issue for us with our fractures or very lame horses, etc. And you just, you know, there's just some stuff that just that horses just won't tolerate, that small animal stuff can get away with, etc.
Yeah. Well, look at I feel like we're all a little bit more informed around around what it entails to do the job that you do. It's a job that is how shall I say, very involved and demands a lot of knowledge and expertise from you guys, and I'm sure the horses that come out the good end of what you do are very appreciative of what you do, and owners in those scenarios are very appreciative of what you do, and I'm appreciative of the time that you've given us. But I've been very bold as a timekeeper tonight.
I know, I apologize, because like I said, but you needed to rein me in, because like I said, I would sit here
it's
and talk
okay. I'm also quite conscious that we had a little bit of delay in the middle of affairs and that as well too, and that in fairness you were trying to get an awful lot in. So look at thank you for all of that. Thank you for those who stuck with us and are still there at this point. Appreciate that, and that is a nod to you and what you're delivering. A note to say that I'm back here on the on the Tuesday, the 4th of April, the first Tuesday of next month, and hopefully that will see the rest of you then. And as usual, Zoom is an abrupt master, and once I hit this button we are gone. So thank you, Anne. And is there anything else you wanted to say before you finish?
Just thank you very much for having me. I really enjoyed it, so I'll come back anytime. And if anyone is very, very interested, they're more than welcome to follow me on Instagram, because I do put up quite a few of my cases and discussions, and anything kind of that I brought up this evening, I normally do have some form of it up on my Instagram. Just again, it's more not only just to plug myself a bit, but also it like shamelessly, but it's also just to let it's for knowledge.
It's informative as well. Yeah. I had a wee look myself, and although some of the material is not for the faint-hearted,
no, it is tailored for vet students, vet nurses, current vets, etc. It kind of highlights treatments, etc. But I think it's informative for clients as well to see what's being done and what happens.
I enjoy this kind of stuff.
Yeah.
But just the note of care for those who don't. So listen, good night for now, and thank you very much.
Nice, thank you.
Take care. Bye everybody.